Now let's start with the first section of our lecture, head and neck cancer. In this section, we will talk about the etiology and classification of head and neck cancer. And also we will talk about the incidence and epidemiology of head and neck cancer. So first, the head and neck tumors, they arise mainly from the mucosal surfaces. They are squamous cell in origin, so head and neck tumors are, the origin is from the mucosal linings, and the most common type of the cells involved in this is the squamous cell. Highly heterogeneous in origin, and the tumors are of the head and neck tumors include the tumors of paranasal sinuses, also tumors of oral cavity, nasopharynx, oropharynx, hypopharynx, and the larynx. So all these are the tumors of the head and neck region. All these areas are involved in the tumors of the head and neck region. Incidence and epidemiology of head and neck tumors. There are about 3% of all malignancies, adult malignancies in the United States. Worldwide incidence exceeds 500,000 cases annually. So 500,000 cases of head and neck neoplasm and tumors occur annually or each year. Nasopharyngeal cancer more commonly seen in the Mediterranean countries and in the Far East region. The etiology and genetics of the tumors of the head and neck. We have risk factors which leads to the tumors. They are alcohol and tobacco. So intake or use of people who use alcohol and tobacco, they have a high risk of developing the tumor, especially of the oral cavity with the tobacco. Nickel refining is another risk factor. Exposure to textile fibers. Woodworking, people who work with the wood or carpenters, they have increased risk. EBV or Epstein-Barr virus infection, salted fish and pollution cause nasopharyngeal cancer. HPV or leads to oropharynx cancer, and HPV is human papilloma virus. So human papilloma virus can cause oropharyngeal cancer. Then we have some dietary factors also that can lead to the tumor of the head and neck region. Carotenoids have protective effect against the tumor. So these are some risk factors which are associated with the development of the tumors of the head and neck region. The classification of the tumors, we have stage T1, T2, T3, and then T4 is divided into T4A and T4B tumors. Then these are the stages of the tumors, and then the nodal involvement, and then the stage grouping of these tumors. So T1 is stage T1 is tumor which is less than or equal to 2 centimeter in greatest dimension without extra parenchymal extension. So T1 are the tumors which are less than 2 centimeter in greatest dimension, and there is no extension into extra parenchymal area. And then the no nodal involvement, no lymph nodes are involved. And then there is T1 is no nodal, NO and MO, no metastasis and no nodes are infected. Then in T2, stage T2, tumors are now more than 2 centimeter but not more than 4 centimeter without extra parenchymal extension. The difference between T1 and T2 is now tumors are bigger than 2 centimeter but they do not exceed more than 4 centimeter, and same, they do not have any extra parenchymal invasion or extension. No metastasis to the regional lymph nodes. So T2 is no lymph nodes, no metastasis. Then now stage 3T. T3 is now tumors are more than 4 centimeter or tumor having extra parenchymal extension. So T1 and T2 are without extra parenchymal extension, and T3 now have extra parenchymal extension and also tumor more than 4 centimeter in greatest dimension. So both can occur or either one of them should be present. So it's and or, so any one or both. Lymph node is metastasized, the tumor is metastasized to one lymph node area, so N1. Metastasis in a single ipsilateral lymph node, less than 3 centimeter in greatest dimension. Now the tumor starts spreading to the ipsilateral lymph node. And then the stage grouping is T3 NO-MO, T1 N1-MO, T2 N1-MO, T3 N1-MO. Then in T4B, we have tumor invades skin, mandible, ear canal, or facial nerve. Now it extends into the extraparenchymal region, and all these regions are affected by the tumor. N2, and then we have a metastasis in single ipsilateral lymph node more than 3 centimeter but less than 6 centimeter. N2B is metastasized in multiple ipsilateral lymph nodes, none more than 6 centimeter. N2C is now in bilateral or contralateral lymph nodes. Now, if you see the stage T4A is now very severe condition or bad staging of the tumor, because now the tumor is spreading to the skin, mandible, ear canal, and also ipsilateral or bilateral lymph nodes are involved, which are between 3 centimeter to 6 centimeter size. So now it's more and more extensive and bad progress of the tumor. Then we have stage T4B, which is tumor invades now the skull base or pterygoid plates or encases carotid artery. Now the tumor is spreading to the actual brain or the skull base. Lymph node is N3, metastasis in a lymph node more than 6 centimeter in greatest dimension. So we have T4A was up to 6 centimeter, now it's more than 6 centimeter, widespread to the different lymph nodes ipsilaterally or contralaterally. And then the stage grouping is T4B, NEN, MO, NET, N3, and MO. So these are the classifications of the tumor in which we said that type 1 is, so T1 is early, no spread, and there is no lymph node involvement, no metastasis. So staging is very important. In the early stage of the tumor, the diagnosis is, if diagnosed, prognosis is very good as compared to the stage T4B, when the tumor is widespread even to the base of the skull, pterygoid plate, and also to the carotid artery. So once it reaches that site, then there is no point of return. So early diagnosis for the tumor is very, very effective. So this was all about section 1. Thank you for watching sqadia.com.